Yes, because it's getting recorded now. Probably you might have yeah.
We have I can find it.
They have the same triangle. This is Again,
Madam? I'm good. I'm at the Castle Street. Physician.
Very prestigious schools. I think Priyanka started with
Yes.
UCP compliance 217. So people do UCP education, compliance 217. I know, I haven't received.
They're both medicines. We'll ask the first person to come inside.
Is anyone interested in sitting to complete that listen?
Okay. This is the recorded session. Then later on, no. At the moment, no one.
They are recording and
Hi, let's start. We'll bring the first presenter inside. So, Kaditya, Satya. Good afternoon. Good afternoon, everyone. Welcome to the second session of the oral presentations of the annual conference 2020 of Ceylon College of Physicians. OP7, oral presentation 7, is autonomic functions among fuel handlers in the Gampha district. The authors are Dr. Madhagoda K, Dr. Kotahachi D, Dr. Luke D, Dr. Vadasinghe D, Dr. Aryavansa D, Dr. Aryavansa J, Dr. Ratnayaka P, Dr. Disanayaka T, Dr. De Silva D, and Dr. Devanarayanan N. The presenting speaker today is Dr. Varna Kulasurya T. Good afternoon, everyone. Today we are going to present the study on autonomic functions among fuel handlers in the Gampha district. And this is a part of the study where we evaluate the health effects of exposure to fuel among fuel handlers in the district. Sri Lanka has seen exponential economic growth and with it an increasing number of motor vehicles, and air pollution due to these increased vehicle emissions have been related to adverse health effects. And the Department of Motor Traffic in 2015 reported about a 3 times higher registration of vehicles, of which 96% of them used either petrol or diesel as a fuel. With this, number of fuel stations and number of employees within them have increased due to the demand. And there's a long working hours to these fuel handlers. And in the same study that we did, our Netherlands collaborators examined the VOC levels within the expired air, and it was seen that fuel handlers are exposed to more volatile organic compounds such as benzene, toluene, and cyanide. The central and peripheral nervous system is affected by these pollutants, and altered heart rate variability have also been seen on exposure to these air pollutants. So our objective was to determine the changes to cardiovascular autonomic functions and heart rate variability measurements among fuel handlers in Sri Lanka. And the ethical approval for the study was granted by the Ethics Review Committee of the Faculty of Medicine Municipal Government. And we selected 7 fuel stations in the Kampala district, where 50 male handlers were chosen consecutively for the study. 46 agent gender matched individuals were recruited from the Ragam and Voyage area as controls. After giving them the information about the study, informed written consent was obtained. Then an extensive questionnaire was filled out, and the physical examination was conducted by a consultant physician. The organ function assessment and heart rate variability measurements were performed using alternative protocols at the Medicine University of Kenya Department of Physiology, where we have national unit. The subjects were pre-prepared for the test, and the advisory refrained from any beverages containing caffeine, nicotine, and alcohol, and any medication that could alter autonomic functions were accepted as well. And we tried to complete the autonomic function assessment between 9 a.m. to 11 a.m. in all the subjects. They came in fasting and had a preset meal, a standardized meal, after which they were rested for 30 minutes before the baseline parameters were recorded. 5 minutes of continuous ECG was recorded using the PALAB, and it was analyzed to have software of Charlie or heart variability analysis. The autonomic functions we conducted were parasympathetics, the heart rate variation during breathing, and then immediate heart rate response to standing and head up tilt, and heart rate response to Alzheimer's maneuver. The sympathetic functions evaluated by blood pressure responses to standing and head up tilt, then isometric hand grip exercise to hold pressure response, as well as blood pressure responses to mental variabilities. Heart rate variability measures the variation in the RR interval between consecutive heartbeats. And this uses both time domain measurements and frequency domain measurements to measure the parasympathetic as well as sympathetic functions of the heart. Because the autonomic parameters were not normally distributed, we use non-parametric methods for data analysis. Moving on to the all-important results. There were no significant differences in the weight, height, or the body mass index, and of course, they matched the age. So these are the parameters that could alter autonomic functions between the two groups. So they were comparable between the handlers and the controls. The baseline parameters, the heart rate is lower among handlers, but the supine systolic blood pressure and supine diastolic blood pressure was significantly higher among the handlers compared to the controls.
The resting heart rate, although low, was not significantly low. Among the cardiovagal parameters, the Valsalva ratio was significantly higher among the full handlers, and this is a parasympathetic parameter. So the Valsalva maneuver is performed, the RR interval is measured right after the strain, and then RR interval is measured within the strain, and the ratio is calculated, and it was significantly higher among the full handlers. Other cardiovagal parameters were comparable between the two groups. Of the sympathetic parameters, a rise in diastolic blood pressure on sustained isometric hand grip was significantly higher among the controls. So it was significantly lower among the full handlers. So this was a sympathetic parameter which was lower. The other sympathetic parameters were comparable or similar between the two groups. Moving on to the heart rate variability, the standard deviation of RR interval, or SDNN, is a global parameter of the autonomic functions. And this heart rate variability parameter was significantly higher among full handlers. All the parasympathetic heart rate variability parameters were also higher in the full handlers, although only SDNN was significantly high in the full handlers. When we measure the exposure hours within a week and the parameters, the baseline diastolic blood pressure significantly reduced with higher exposure hours per week, and delta heart rate during inspiration and expiration, which is also a parasympathetic parameter, increased with increased exposure hours among the full handlers, and this was only analyzed among full handlers. So similar to our study, higher resting systolic and diastolic blood pressures have been seen in humans as well as in laboratory conditions before. And this is supposed to be attributed to oxidant stress and catecholamine release causing a vascular response. A lower heart rate, higher Valsalva ratio, and lower diastolic blood pressure rise to sustained hand grip together suggests a cardiac parasympathetic predominance among fuel handlers, and the higher HRV is considered to be beneficial and cardioprotective and also shows a parasympathetic predominance, and the higher HRV parameter supports the finding of in the autonomic function analysis. So in conclusion, altered autonomic balance was observed among fuel handlers with parasympathetic predominance to the heart, suggesting autonomic function alteration on exposure to volatile organic compounds. Long-term health assessment, monitoring of air quality at the workplace, and restriction of hours of exposure per week, and use of protective equipment are always recommended for the fuel handlers. We would like to acknowledge all the participants in the study and owners of the fuel stations who cooperated, all the staff members from 2018 to 2020 who assisted, and the University of Canada Research Grants for funding the study, and the Ceylon College of Physicians for the opportunity to present the findings. These are the references that we used. Thank you.
Okay, now it's time for questions and answers. Jaidas will ask the question.
After the
Why? Yeah.
sir, no, just talk loud. It will be okay.
Yeah, why decide to do this on fuel handlers? Is there any evidence that these cause autonomic neuropathy?
Initially, we did this study to evaluate all the health effects. We focused on autonomic function assessment. We saw there was a gap in literature, that it was not investigated much, but central nervous system alterations have been reported, and they have hypothesized autonomic function alterations. So we thought we should address the gap in knowledge and then conduct this.
And were there any patients who had really symptomatic autonomy, like collapse, fainting, and the ones who have been chronically working for long periods? Did you come across any? Or
they haven't reported any symptoms, but when we analyzed the data, we could see that orthostatic hypertension was present in about 20% of the fuel handlers as compared to the controls, but the controls also...
So there was no one fainting at work? Or
no, none.
Had there been any previous studies in somewhere else internationally on this type of?
Yes, in India as well as in Turkey and Spain, they have assessed fuel handlers and autonomic functions, but they have mainly used heart rate variability as a parameter to measure autonomic functions. Whereas we did both cardiac and cardiovagal parameters and sympathetic parameters using evenings protocols, as well as heart rate variability parameters and correlated with US.
So based on your findings, that was the clinical implication. I mean, I say if you have to give recommendation to the fuel owners, the ship owners, then what would be the recommendation?
At the moment, we haven't found anything negative towards it, but just that autonomic functions are altered among the fuel handlers. So this was a subsection of a large-scale study where we found respiratory parameters and other things as well, which we are only presenting the autonomic functions today. But here, what we're saying is the central nervous system is altered with exposure to volatile organic compounds. But here, what we found was a more parasympathetic predominance, which is suggested to be more cardioprotective than harmful.
what were your controls?
Controls are age match, people who were not occupationally exposed to any fuel from the rather remote area, we advertised, and then people who volunteered for the study were recruited after exclusion criteria, which included exposure to all of the volatile organic compounds.
So are they better looked after group because their blood pressures are generally okay, whereas this group kind of economically not well to do and their blood pressures are not checked, their blood pressures are high? Can be like that because your control will be kind of
yes, we haven't looked at the data, but the monthly income were not significantly different. But that would be the only economic parameter that we assess.
What's your comment with regard to sample size?
We would have liked to increase the sample size, but there were restrictions because of limited funding.
So is that enough for us to make conclusions?
Yes, because we have we calculated the sample sizes, and we needed 25 in each group to come to a conclusion. But we tried to increase the sample size so that we could get after technical errors of exclusion of persons, we could still come up with a comparable sample size. So that we opted for 50, which was double the required sample size.
So this is a cheap study. You don't need to spend money.
Autonomic function.
To make it 100 or 200.
The thing was that we actually, the autonomic function was a part of the study where we did a lot of other biochemical, endocrine, as well as lab function analysis, which required a lot of money.
Right, thank you.
Thank you, madam. It's very audible. It's not very much audible.
No, wait.
This one is let us know.
So you want to change the color, yeah? The color is definitely change. You want to make it more dark or red though? Now also you can see here.
This outcome is so we also use it.
8 weeks,
8 weeks and 2 weeks for questions, sir. Okay.
Oral presentation 8, seizure patterns, preconception care and pregnancy outcomes in women with epilepsy in a tertiary care hospital. The authors are Dr. T.S. Palihavadana, Dr. C. Jayasinghe, Dr. U.K. Ranawaka. The presenting author today is Dr. M.B.C. Mota.
Good afternoon. Let me share with you our study on seizure patterns, preconception care, and pregnancy outcomes in women with epilepsy in a tertiary care hospital. Epilepsy is a relatively common neurological problem that affects 3 to 4 per 1,000 pregnancies. However, data on epilepsy in pregnancy is limited in the South Asian region. Our aim was to describe preconception care, seizure patterns, and pregnancy outcomes in women with epilepsy attending a Sri Lankan tertiary care hospital. All pregnant women with epilepsy admitted for delivery to the University Obstetric Unit at the Colombo North Teaching Hospital during a 3-year period were recruited for the study. Women with a history of epilepsy confirmed by clinical records were included. Data were collected by a single physician using a structured research questionnaire following informed written consent. Data on preconception care and seizure pattern was obtained via direct questioning and medical and obstetric records. For fetal assessment, a single pediatrician examined all neonates for predetermined dysmorphic features, cleft lip, cleft palate, and hypospadia. Prior to discharge, all neonates underwent a 2D echo and ultrasound abdomen. Ethical approval was obtained from the Ethics Review Committee of the Faculty of Medicine, Calenium. The results. Out of 9,520 pregnant women during this period that was screened, 63 had a history of epilepsy, giving rise to a prevalence of epilepsy of 6.6 per 1,000 pregnant women. The mean age of our women was 28.7 years, and up to 90% of them had some form of secondary education. The seizure type is given here. Nearly 3/4 had generalized epilepsy, nearly 1/4 focal, and the rest, the type of epilepsy could not be clearly identified and they were grouped as unclassified. And the pie chart here gives a more detailed breakdown on the type of epilepsy. With regard to preconception care, out of the 63 women, 53.9 received some form of preconception counseling prior to embarking on their pregnancy. Out of the women who were on antiepileptic drugs prior to conception, only 42.7% of women received the recommended dose of folic acid, which was 5 mg. 50% did not receive the recommended dose, and 5.2% of women were unaware whether they were on the recommended dose or not during the periconception period. When we looked at the seizure pattern, in the preceding 2 years prior to the pregnancy, 42.9% did not have any seizures. 57.1% did have seizures, and 28.6%, more than a quarter, had one or more seizures over the last 6 months, the 6 months prior to their pregnancy. When we looked at the seizure occurrence in their current pregnancy, more than half, 55%, had seizures either during pregnancy or in the 3 months following the pregnancy. And the table below gives a more detailed breakdown showing the seizure occurrence according to the trimester and up to 3 months postpartum. And as you can see, it is during the 3rd trimester that the occurrence of seizures is highest, followed by the 3 months postpartum, the 2nd trimester, and then the 1st trimester. When we did a small analysis to look at the cause for seizures in pregnancy, unsatisfactory drug compliance accounted for 8.4%, sleep deprivation in 2.8%, but in the majority of women, the cause could not be identified. When we looked at the anti-epileptic drug use in pregnancy, at the time of conception, 71.6% of women were on one drug only, more than a quarter were on 2 drugs, and none were on more than 2 drugs. When we looked at the modification of their medication during pregnancy, 6 women had 1 drug being added, 1 woman had 2 drugs being added. There was a change of their medication in 17 women, and 25 women had no change in their drug regimen during the course of their pregnancy. Now, the all-important pregnancy outcome. 61 live births occurred, 1 stillbirth and 1 neonatal death. 66.7% ended in normal deliveries. Cesarean section accounted for 33.3%. Hypertensive disorders, which is a known association with epilepsy, was seen in 22% of women, with pregnancy-induced hypertension in 6%, preeclampsia 14%, and eclampsia 2%. When we looked at the fetal outcomes, prematurity was seen in 9.5%, low birth weight in 42.8%, and major congenital malformations in 11.1%. And the breakdown of congenital malformations is given here: cleft palate in 1, cardiac anomalies in 6, ASD 4, ventricular septal defect 1, and a patent foramen ovale in 1. And the other congenital malformations that we look for are listed below, but were not seen in any babies. And we looked at the seizure patterns in pregnancy and the anti-epileptic drug use at conception in the mothers of babies with congenital malformations. And all except 2 women had seizures in pregnancy. And all women were on anti-epileptic drugs at conception, 5 of them on polytherapy. This led us to look at the probable association between seizures in pregnancy and firstly seizures in pregnancy and the occurrence of major congenital malformations. And what we found was that seizures during pregnancy gave rise to an odds ratio of 2.17 for the occurrence of major congenital malformations. However, this association was not significant. Secondly, we looked at the use of anti-epileptic drugs during conception and major congenital malformations. This gave us an odds ratio of 12.14, and it was not significant. However, the use of polytherapy at the time of conception versus monotherapy or no therapy gave rise to an odds ratio of 20.83 for the occurrence of major congenital malformations in our women, and this association was significant. To conclude, our study showed that preconception folic acid coverage and counseling was inadequate. The majority of women had experienced seizures during the preceding 2 years prior to the current pregnancy. Seizures occurred in more than half of women during pregnancy and were more in the 3rd trimester and postpartum. Hypertensive disorders, major congenital malformations, and low birth weight were high in our population. Cesarean deliveries and premature rates were not high. Anti-epileptic drug polytherapy at the time of conception was significantly associated with a higher risk of major congenital malformations compared to mono or no therapy. And therefore, I would like to conclude by saying that our data adds to the limited body of data available on women with epilepsy in Sri Lanka. So far, we have only one study done in Sri Lanka with regard to women with epilepsy, and therefore we can say that our study data is the first to reveal information on preconception care and seizure patterns in Sri Lankan pregnant women. Thank you.
Okay, now it's Q&A. Judges can ask questions.
Your findings, are they comparable to the previous studies that had been conducted, or are there?
Yes, madam. So with regard to the results, if you look at I told you there was one study conducted in Sri Lanka, and it was published 2 years ago. They looked at if you looked at the major congenital malformations, it was 9 point something. It was 9%. So ours was 7.1%. But they looked at the seizure frequency in pregnancy, and they found that 64% of women did not develop seizures in pregnancy, whereas we found that 45% of women did not develop. So we found a higher incidence of seizures in pregnancy. When we looked at the international data, it was somewhat comparable, except for our low birth rates, which were higher than the international data. The highest incidence was 38%, whereas ours was 42%.
Birth weight.
The low birth weight. So that was the only thing that was not comparable, but the rest of the data appeared to be comparable to international data.
Other than the number of drugs, whether it's monotherapy or polytherapy, did you check individual drugs, whether one particular drug is more associated with congenital malformations than the other?
Individual drugs.
Yes.
We did not analyze that. No.
Don't you think that it would be important?
That would be important, but because our sample size was small, we were wondering whether that would whether it would be powered, whether our study would be powerful enough to look at that association. We were thinking that we
I
needed.
think the main problem is your sample is pretty small.
Yes, sir.
So when you compare it, the study is important. What was their sample?
The study that was done in Sri Lanka, the sample size was 9 to 6. And the international studies, of course, they were kind of registries where they had thousands, like 20, 30,000. So they were mainly registries, like the Europe study. So I think in the large studies to look at the individual drugs and their effects. I think our study was not enough to look at
with
that.
With regard to folic acid,
yes.
What's the recommendation there?
The dose,
is it for necessary for all drugs?
The most of the antiepileptic drugs, at least the older generation drugs, they exert the therapeutic effects to anticholic effects. But the newer drugs like lamotrigine, they are much more safe. Thank you.
Yes.
Oral presentation 9, incidence and prevalence of stroke and time trends in vascular risk factors among urban, semi-urban Sri Lankans, a population-based cohort study. The authors are Dr. Vikramaratna KB, Dr. Padmeswaran A, Dr. Vikramasinghe AR, Dr. Ranavaka UK. The presenting speaker today is Dr. Shamila Mettanand.
Good afternoon. We studied incidence and prevalence of stroke and the time trends in vascular risk factors among urban and semi-urban Sri Lankan population-based cohorts. We know stroke is a very important health problem in the world. It is the second leading cause of death in the world. And of all these deaths, 85% comes from developing countries. So it's a very important problem for us as well. If you look at the global incidence of stroke, it has declined by about 8% from 1990 to 2016. In all, if we look at all the countries, the trend is for a drop, but except in East Asian countries, where like the countries in the middle socio-demographic index, they actually have higher incidence. Like it's not a dropping trend, it's increasing, like in China and North Korea like countries. We don't know where we lie because we do not have data on the incidence of stroke in Sri Lanka. We do have limited data on the prevalence of stroke. We have two main studies, published studies, one published by Ranawat et al. In 2007, where we studied the prevalence of stroke in a semi-urban population, where the rate they detected was 9.6 per thousand population. And Chang et al. In 2015 reported a prevalence of 10.4 per thousand population in an urban population in Colombo. Since there are no data on the incidence of stroke in Sri Lanka, we sought to look at the incidence of stroke in a population-based cohort from Sri Lanka. And at the same time, we compared the time frames in prevalence of risk factors during the follow-up period. So our study cohort consists, it is a part of the Ragama Health Study Project. So our study cohort consisted of participants between 35 and 64 years of age, selected by stratified random sampling of the Ragama Medical Officer of Health area. So in 2007, we collected data on medical history and vascular risk factors from this our study cohort, and then we re-evaluated them in 2014 to find out the onset of new stroke and what happened to the risk factor status. So if we look at the baseline cohort in 2007, we had 2,985 patients. The mean age was 52 and 55% were female. And there were 19 stroke patients who already has had a stroke at the enrollment. 47% were female, and there was only one ICH at the baseline. And with that, the prevalence of stroke in our study was, when calculated, it was 6.37 per thousand population. Then we re-evaluated them in 2014. Nearly 75% of the initial cohort came for the follow-up, and we detected that there were 24 new strokes of the people, that 2,204 people who came for the follow-up. Of the 24 new strokes, 13 were female, so the percentage-wise 54% were female, and nearly 80% of the patients has had CT brains done, and there were 3 ICH patients, and 3 patients came with recurrent events, and there was 1 death. With this data, we calculated the annual incidence. It was 1.56 per thousand population. In other words, it is 156 per 100,000 person years. Later, we compared the risk factor prevalences in 2007 with 2014. So you can see, like, so the blue bars are 2007 and the red bars are 2014. All the risk factors have, the prevalence has increased except smoking, where it's only the smoking has gone down. But we have to appreciate that these people, they have aged by 7 years. So that also has played a part in this. Therefore, let ladies and gentlemen, in conclusion, this is the first report on incidence of stroke from Sri Lanka. And there we found in this urban, semi-urban Sri Lankan cohort, we found the incidence of stroke was 156 per 100,000 person years. And when we compare it with the global situation, so we know the highest stroke incidence is in China, which is about 355 per 1,000 population, about 100,000 person years. And then the lowest incidence is in Latin America. It is 97 per 100,000 person years. So we lie in between that. We are 156. And then if we compare it with our neighboring country, India, we are closely going with the incidence rate of India, because India, again, when you consider depending on the state, the incidence is different, like it varies from 114 to 150. So we are closely going with them. But we have to acknowledge the limitations in our study. Since we have studied only the urban and semi-urban population, we can't generalize this data to the to whole of Sri Lanka, because we have not included rural community in this. And the other thing is an ideal incidence study need to follow up all the age groups. Like you have to take a sample all without considering their age, and you have to follow them up for 1 year and see how many strokes would occur. But our one is a selected group, so this is not a proper incidence study. But given the situation, like for the incidence now we have found is like 156 per 100,000 population. So to catch that amount of strokes, we will have to follow up a huge number of people, which is not practically possible. So that's why we have sought to do our study in this way. Thank you. So like ideal study, as I told, would have been to like select say from random medical officer of health area, take a random sample of all ages. Yeah.
This one from Sri Lanka, this 156 per 100,000, that will be very misleading, because you are taken an age group where you don't get strokes.
Yes.
The 65, 75.
Then you could have. Yes. So that's yes.
So when you say incidence, you have to always say this is the age.
Yes.
When you go internationally or somewhere and say that our incidence is 156.
Yes, this is in the 35 to yes. So actually these are the China one and the Latin America one, that is the age standardized incidence. We are also now the next step is to do a age standard. Yes, that's it. Otherwise, yes, that may be the main reason why, like, so the stroke prevalence again. So the previous documented studies, the prevalence is around 10%, whereas our one is 7%. That's because we have excluded the very elderly population.
Yeah, is it 75% return to the baby?
Yes, that's 73 point.
By other than 25% that who died with the died of stroke.
Madam, so like, Madam, we have like, so we like, so we called them, we tried our best to like ascertain all the patients. So like we have tried gone to their houses and tried to contact them, and we have so the people who madam, no, this here we have calculated using only the 2,204 patients, not from the initial. So like so it's only these 2,204 patients followed up for 7 years. So we calculated the incidence from those people only, because like
So you did not compare?
no. We call them to, we have a Ragaman health, we have an ongoing clinic, so we posted them letters and we called them and asked them to come, and for the people who died, we asked them to come with the death certificate. So we have gone to either medical certificates or the death certificates.
That's what I asked.
Yes, we have not included them. Yes. So initial number was 2,950.
You did not, when you were to compare, you did not take that 2,000.
No, we calculated only the 2,204. Those are the people who were followed up for 7 years. So initially there were like 100, but only 75 came for the follow-up. So with that 75 only, we calculated the incidence. So the people who did not come, so like they were excluded from the calculation. So like 2,204 patients followed up for 7 years. That was the person years that started.
So this happened when you minus money to something else.
Yes.
No?
Yes.
And then now it's a new incident.
Yes. Thank you.
Thank you, madam.
Shall we proceed, sir?
Oral presentation 10. Usefulness of Berg balance scale, 6-minute walk test and timed up and go test as fall risk predictors in post-stroke adults attending Rehabilitation Hospital, Ragama. The authors are Dr. Padmeswaran A, Dr. Ranavaka UK. The presenting author today is Dr. Bandara KMT.
Good afternoon, Joel. I am Tananga Bandar from the Rehabilitation Hospital. I am a physiotherapist. The title of my presentation is Usefulness of Berg Balance Scale, 6-minute walk test and timed up and go test as for these testers in post-stroke adults attending Rehabilitation Hospital Ragama. Stroke is the second leading cause of death, and more than 80 million of stroke survivors can be seen worldwide. Frequent falls may have negative impact on person's functional independence, but do you know that falls can be predicted as well as prevented? Why this falls is so important? Because it increases the length of stay at hospital and also healthcare cost and negative impact on rehabilitation process. In this sense, fall risk prediction and prevention must be a key component in stroke rehabilitation. After the stroke incident, the impaired balance, mobility, and walking capacity can be seen. And to assess these impairments, we can use Berg balance scale, 6-minute walk test, and timed up and go test as valid and reliable clinical tools to predict the fall risk. And my general objective is to determine the usefulness of assessment of mobility, functional balance, and endurance in predicting fall risk among stroke patients. And specific objectives were to describe the fall incidence and to assess the functional balance, walking capacity, and mobility of the patients with and without falls using the following scale: BBS, 6-minute walk test, tap test, and to identify a cutoff value for these three tests that can predict falls. This was a cross-sectional descriptive study and physiotherapy department. It was done, the study setting was the physiotherapy department at Rehabilitation Hospital Ragama. It was conducted from May to August in 2019, and the study population was first ever stroke survivors within past year, 12 months. And this is my inclusion and exclusion criteria. Our sample size was 74, and data collection, standard data collection done by a standard data collection form, and all the participants participated with the 3 clinical tests: BBS, 6-minute walk test, tap test, and this data analysis done by SEIZURE software, and receive operating characteristic curves and area under the curve used to determine the cutoff values and fall prediction. This Berg balance scale is the test with 14 components with the task or the functional task of the daily activities, and the maximum score is 56. If the Berg balance scale less than 45, it indicates fall risk and impaired functional balance. 6-minute walk test used to assess the functional walking capacity of stroke individuals, and the distance walking within the 6 minutes time assessed, and if the walk distance less than 285 meters, it indicates low walking capacity and with fall risk. And timed up and go test used to assess the functional mobility of the patient, and patient was asked to get up from the chair and walk 3 meters ahead and then turn and come back to the chair. The tug time, if the tug time exceeded 14 seconds, it indicates impaired mobility with fall risk. These are the results. We'll move on to the results part. We recruited 74 stroke patients. There were 50 males and 24 females, and only 17 had history of falls. There was no significant difference in baseline characteristics such as gender, age, duration from stroke onset, and stroke type, and use of assistive devices. This is the results of the BBS in relation to the fall history. Here, in this table shows 88% of fallers showed less than 45 in Berg score, and only non-fallers, 47% non-fallers scored less than 45, and the BBS was statistically significant with the fall history. And the post cutoff value according to the ROC curve for this study population in the Berg balance scale is 45, which is equal to the internationally recognized cutoff value. And area under the curve of the Berg score was 0.773, which indicates for the Berg balance scale can predict falls. And results of the 6-minute walk test shows 88% of fallers and 66% of non-fallers couldn't complete the distance to more than 285, showing high fall risk. And 6-minute walk test also statistically significant with the fall history. And proposed cutoff value for the 6-minute walk test for this study population with the stroke and to assess the fall with the falls is 193 meters. Area under the curve was 0.686, and 6-minute walk test also can predict falls. Tuck test results: 94% of fallers and 86% of non-fallers exceeded the tuck value, and it indicates high fall risk. And proposed cutoff value of the tuck test for the fall prediction in study population in stroke individuals is 23 seconds. And area under the curve of tuck value was 0.662, and the tuck test also can predict falls. This is the first study addressing fall risk in Sri Lankan stroke patients. And we studied 3 commonly used scales to predict fall risk in Sri Lankan stroke patients, and all 3 scales were able to predict fall risk. And Berg balance scale performed better than tuck test and 6-minute walk test in predicting fall risk. And in conclusion, Berg balance scale, 6-minute walk test, and tuck test can be used to predict fall risk, and also we can assess functional balance, endurance, and mobility in Sri Lankan stroke patients by using these scales. These are my key references. I would like to acknowledge participants and the Deputy Director and the consultants and the Physiotherapy Department at Rehabilitation Hospital, Ragam. Thank you very much.
Now it's a time for questions from the judges.
Inclusion criteria include the stroke patients within the past 12 months, and the minimum of 3 meters. I need to walk minimum. So I wanted to the minimum of walking within the 12 months of period with the rehabilitation process. Ability to walk 3 meters is the minimum.
Between the fallers and non-fallers. Similar. So you are predicting that they might fall at the cutoff rate.
Yeah.
You apply that to non-fallers and see whether the non-fallers below that cutoff rate. Follow them up, that's way to predict whether it really works. Whether they fall after you have a
Fall was assessed with the subjective interview from the fallers, both participants, and they are so I couldn't understand what
like the non-fallers and of those who fell below the cutoff rate. So if you look at them afterwards, did they fell down after that?
Actually, I didn't did the follow up. Didn't do the follow up, but if most scales are only for all the adults, not for the cutoff values, mostly used with the elderly adults, not for the stroke patients. That's why I wanted to introduce a new cutoff value for the stroke individuals actually. Because of that, I wanted to introduce new cutoff value. I think if the cutoff value I apply new cutoff value for stroke patients, I think the data can be changed.
And you had used SPS, statistics.
Yes,
like the other side of statistical evaluation, no? Yes.
Thank you, madam.
This investigated the stories of deformer and
No, she did study the physical. She did the study in the physical. So they all had a physical disability. Right? They
not follow.
Then she studied how many were with falls, with the history, how many were with falls and how many were with good. And then she compared those two to see that whether there was a disability difference, age difference, fallers and non-fallers. And then she developed
applied the scales.
yes, applied the scales among the fallers and non-fallers. And then she said that there is
you can use the predictions to say that you like fall so that you can take it.
But the study design was to come up with this. That's another study. That's back to validity. Yes, validity. Yes. She. Do you have right.
Oral presentation 11. Utilization and outcome of thrombolytic therapy in acute ischemic stroke in a tertiary care setting. The authors are Dr. Senanayaka HMS, Dr. Lukunarangoda MC, Dr. Veeravansa MRP, Dr. Philippitia SD, Dr. Sarat Chandra C, Dr. Pushpakumara PhGJ, Dr. Siribardana S. And the presenting author today is Dr. Ratnayaka RMCE.
Good evening. My topic is utilization and outcome of thrombolytic therapy in acute ischemic stroke in a tertiary care setting. Moving into the introduction. Again, my topic is utilization and outcome of thrombolytic therapy in acute ischemic stroke in a tertiary care setting. moving first into the introduction, intravenous thrombolytic therapy with tissue plasminogen activator, commonly named actylase or antiplase, is a well-known evidence-based and effective treatment for acute ischemic stroke. The benefit of thrombolysis is seen only if it is given within 4.5 hours from the onset of stroke symptoms. So the objectives of my study were, the first objective was to describe the efficacy of delivering thrombolytic therapy. Here I have defined it with timelines, symptom onset to admission time. That is basically the time taken by the patient from the hospital, door to CT time, meaning that OPD admission to take the CT, and onset to needle time and door to needle time. The second objective is to describe the outcome of thrombolytic therapy. And here, based on recovery of the thrombolysis, I have explained the recovery objectively with National Institute of Health stroke scale, modified Rankin scale, and Barton index score. And the negative outcome, the hemorrhagic number of patients with hemorrhagic transformation, and number of deaths, basically in hospital morbidity and mortality. And this study was carried out in the medical board of Professorial Unit Teaching Hospital Anuradhapura, and their stroke registries maintaining since from 2016, and the data, most of the data were collected prospectively as well as data were recruited retrospectively during the time period of 2016 to March 2016 to June 2020. And the most importantly, this study did not interfere with the standards of patient care, and all patients were managed as per accepted guidelines. And coming to the most important part, the result, the efficacy of delivering thrombolytic therapy. The first timeline I mentioned here is the symptom onset to admission time. Here you see the mean onset to admission time is 190, nearly 2 hours of period. The majority of patients have lost 1.5 hours to come to the hospital. So only 33 patients has come within 1.5 hours time window. And go to CT time. Here the accepted time cutoff depends on the followed guideline. According to the Royal College of Physicians UK guideline, they accept go to CT time less than 60 minutes. But according to the American Heart Association latest update 2018, they accept less than 20 minutes. But in Sri Lanka, crudely we take 40 minutes as the time cutoff. And here in our study, there were 86 patients where the door to CT time was less than 40 minutes. But if we go by the American AHA guideline, it was only for 24 patients as a percentage 22%. In total needle time, the standard cutoff is 60 minutes, but here the mean total needle time was 77, which has reached the standard time limit. And most studies recommend that at least 50% of patients should be within the range of less than 60 minutes. But anyway, in our setting, the achievement was only for 33.9% within the less than 60 minutes of door needle time. And mean onset needle time was 193. It was 3 hours, and majority of patients you can see were thrombolized within the time window of 3 to 4.5 hours, as a percentage 65.7. Coming to the outcome of thrombolytic therapy, here I have categorized the severity of the stroke as 1 to 4 category, mild stroke, and 5 to 15 moderate, and 6 to 20 moderate to severe, and 21 to 42 the severe disease. And I have compared it with the NIH score on admission and NIH score following 24 hours of thrombolytic therapy. And here you see there are none in the 0 category. Of course, 0 if the score is 0, it is not an indication for the thrombolysis. But following the 24 hours of thrombolytic therapy, 4 has come to the 0 category. And 1 to 4 category, initially on admission, there were 17 patients, and following 24 hours, there were 40 patients. So you can see here clearly, following thrombolytic therapy, the patient has come from the more severe categories to less severe category. That shows the improvement following thrombolytic therapy. And as a mean, the mean admission NIH score was 11.1, and mean NIH score after 24 hours of the thrombolytic therapy is 7.8. So here, if you consider the mean difference, it is about 3.3. And most studies recommend that more than 4 improvement of the NIH score as a significant improvement. So in our setting, there were 39 patients. As a percentage, it was 36.6, had more than 4 improvement of the NIHS score following the 24 hours of thrombolysis. On discharge, the modified Rankine scale was less than 2 and modified Barthel index was more than 15. That means the patients are nearly independent or independent. Crudely, MRS less than 2, there were 58% and Barthel index more than 15, 47. So half of the patients were independent or nearly independent on discharge, and Barthel index was almost 20. That means the patients were fully independent in 22.9%. And as the negative outcome, there were 10 patients died before the discharge. And in most researchers, they mentioned the in-hospital mortality rate in between 8 to 11. Again, we are in between range the in-hospital mortality in our study. And 13 of patients reported hemorrhagic transformation following the thrombolytic therapy, and among 7 have died with symptomatic hemorrhage. And coming to the conclusion, the pre-hospital delay time was more than 1.5 hours in the majority, and the majority received thrombolytic therapy within 3 to 4.5 hours of time window. And prolonged out-to-needle time was noted due to in-hospital delays, and prolonged onset-to-needle time was noted due to pre-hospital and in-hospital delays. Half of the patients were independent, as by score I mentioned, on discharge, and the outcome of thrombolytic therapy could be further improved by identifying and minimizing these delays. So these are the references I have used in my study, and thank you.
Okay, now it's time for the questions by the judges.
You said that your study, you have this stroke registry that has been maintained.
Yeah.
And then you said that this is a prospective study.
Yeah.
If that is the case, what do you think that what would have been the better way to find out the delay in coming to hospital? What sample would have been better for you to decide on delay in coming to hospital?
Actually, the registry is maintained. This sample include only the acute ischemic stroke who has undergone thrombolytic therapy. So, in case most of the data were collected.
So you have data at home, but it's not there. You have the register. To find out the delay. Yeah. You have to include all stroke, no? You have sample at home, no?
Yeah.
Registry has the data of all the strokes.
Yeah.
So this does not give you the.
No, this is only the acute ischemic stroke. Yeah. The delay more
thrombolized.
For the acute
This is only few thrombolized.
Few thrombolized. Yeah. This is the sample only the thrombolized patient.
And then you said that your 10-11% developed hemorrhages.
Yeah.
And then you said that 10 died. Not out of the one's hemorrhages.
Yeah.
But then another 10% or 10 died.
Yeah. No. Altogether, only 10 patients died.
Yes.
Right?
Yes.
Here, and 13 reported hemorrhagic transformation.
Yes.
Out of the 10, 7 that included into that 10, that 7 died due to symptomatic hemorrhage. The other 2 were cerebral edema, and 1 was other cause, maybe aspiration pneumonia, and so on. Anyway, in the sample, only 10 has died.
Thrombolized, non-thrombolized, only 10 died.
Yeah.
No, this is only thrombolized.
Yeah, only
thrombolized.
Yeah. And all 10 are hemorrhage. All 10 are hemorrhage.
No.
Only 7
hemorrhages.
So the cause of death might be different.
13 hemorrhagic transformation.
Yeah, 13 hemorrhagic transformation are there, but they were managed conservatively.
Right.
In hospital, there were no in hospital death. Okay.
So the
They might die
seven who died of hemorrhage.
Sorry?
The 7 who died of the hemorrhage.
Yeah.
What was the initial stroke severity? Were they very severe deficits? Did you look at?
Yeah. You mean the 96 score?
Did you look at
why they develop hemorrhage?
Yeah.
Are they diabetics? Are they with very high blood pressure on admission and with the U control and gain thrombolytic? Why did they develop hemorrhage?
Yeah. Actually, I didn't look into the etiology of that, but the sequelae of the hemorrhage So to decide on that, I have to trace the.
When you compilize,
Yeah.
do you discuss all, say, I mean, do you have follow-up meetings for these patients?
Yeah.
And then do you try to shorten the time windows?
Yeah, actually, the follow-up, we are following up patients in 3 months, 6 months, and
No, I'm not asking that.
Yeah.
I'm asking the thrombolytic program, your thrombolytic, the members of the thrombolytic program, the OPD doctor, radiographer, all these. Do you meet and discuss each and every case after thrombolysis?
No. Actually, the thrombolysis program was started in a teaching hospital at since from 2016. Actually, it is developed gradually and up to not yet come up to that level. And this is only the professorial unit, the medical board professorial unit. So that team, these patients are including only the thrombolyzed by that team. In that
there are other patients.
Other patients in the there are 4 medical units, and there are the patients thrombolyzed in that unit as well. Right. Thank you very much. Thank you.
That concludes oral presentation session 2. I would like to take this opportunity to thank the 2 judges, Dr. Padma Gunratna and Professor Saman Gunathilake. Thank you, sir. Thank you, madam. Champika madam, can you hear me? Can you please unmute and...
I can hear you.
It's all clear?
All clear.
Okay. We will be starting as soon as the previous judges are done with the evaluation. That will be within a few more minutes. Okay. Thank you, madam. Also, madam, I can only ask to unmute you, but I can mute you from here. You're comfortable unmuting yourself, no, madam?
I will unmute from here and only on it when I need to speak.
Okay, okay. So, okay, okay. Hello? You'll have to increase. I don't know. Speak a bit louder. Alexa, can you please go?
Check one.
It's again.
Check one.
Yes, it's okay. Sir, your file is there, sir. Sir, the presenter will be here, sir. The other judge has spoken to Champika madam is online. The presenter will come here. Yeah, so Champika madam is online. Presenter will be here. She's the other judge. She's Champika Bodhinayaka. She's online. Presenter will be here. The presentation will be projected on the screen. They will scroll up, down, and zoom in and out as they wish. And are they going to describe it? Yes, they will be describing it. 2 minutes. 2 minutes. 3 minutes for the
3 minutes for the presentation, sir, and 2 minutes for the questions.
2 minutes for the questions and 3 minutes for the presentation. So there will be a timer with an alarm.
You can talk to her.
She's here.
Can ask, tell her to ask the question first, and then, or you can ask alternatively. You ask.
You can talk to her. Yeah. She's online.
Hello.
That's what we need to understand.
Hello.
So you can alternatively ask questions or whatever.
Okay. Okay, madam, can you hear, sir?
I heard. If you want, I can ask alternatively whatever he prefers. Right?
Hello.
Hello.
1 second, madam. Unmute her.
Unmute her.
Mute her.
Is blocking.
Begini dia keren kamu lihat dulu. Kamu bi.
Yeah. Madam, give us another few minutes, madam. There's a small vehicle parking and blocking in issue.
Sure.
Okay, madam.
Test one. Test one.
You can hear me?
Yeah. I can hear.
Then it's also. This is on there?
Yeah.
Ani acara mikro. Kita di. Kita di sini.
නෑ මගේ තමයි පේන්නේ. because මම දාලා තියෙන slide එක. Check කළා තියෙන දැන් සතිසයන විතරයි තියෙන්නේ. Madam is on. Yes. Six was to come now. 6 was to come in a little while. I'll tell you the time. Second half is to come at 16:40. මේක පටන් ගන්න තියෙනවද? මේක පටන් ගන්න තියෙන කොහොමද? අසිල්සර්ගේ වෙහිකල් එකේ හින්දා මේ පද්ම මැඩම්ගේ වෙහිකල් එක බ්ලොක් වෙලා. Madam, sir is here. Can you hear
Hello.
me? Yes, sir is here, madam. Just a small